Now, Allison?
Yes, that would be great.
Okay, sure. So hi, everybody. I'm Tracy Gaudette, and really excited to be a guest with you today. And I hope that I can serve you well. That's my only goal, is to contribute to your great and important opportunity in any way that I can. I'm a physician by training, obstetrician gynecologist, actually. And most of my career, I have been focused on trying to contribute to driving a transformation in healthcare, broadly speaking, to not only do disease care really well, but actually to help drive a change where our system is designed to promote health and well-being and healing across a person's lifespan, and have been working in that world for quite some time. I am currently in Bentonville, Arkansas, as the executive director of the Whole Health Institute, which is a private operating foundation working to drive this transformation. And prior to that, I was in the VA for 8 years working at the national level. And that's how I know Dr. Andy Pomerantz. Hi, Andy.
Great, thank you. We'll be asking you lots more about yourself, but just wanted to level set the group to let them know who you are. And so, Dr. Levine, I think you're up.
Good morning, everyone, and good morning, Tracy, and welcome. I'm Mark Levine. I'm an internal medicine doctor by training and currently Commissioner of Health for the state of Vermont. So we are very interested from a whole health standpoint in a healthier population, in all things population health, and in the work of this council, which really tries to be very integrative in its approach to overall health. I guess we could just plunge in, and I thought we would start by Allison and I giving you a little sense of the healthcare scene in Vermont, if you will. We're a long way from Arkansas.
And I'm not comment on that, but that might be a really good thing. But
well, yeah, tongue in cheek, it is a good thing, because when you look at all the surveys of the healthier states, we are diametrically opposed, with us at the top of the heap and Arkansas in that bottom grouping.
Exactly right. Exactly. We're diametrically opposed in lots of ways, but I just moved here, just so you know.
Okay, we won't hold you responsible or accountable by any means. And we won't be smug, neither, but the reality is most of the issues that surround why we are so opposed have to do with health equity.
Yes,
and that is a dominant theme in the state of Vermont right now. And it's a major core component of our state health improvement plan. But we're going to talk a little bit right now about health care. And what you may or may not know about Vermont is it's always tried to be a very, very progressive state.
Yes.
And to the point where the governor that came before our current governor, Phil Scott, Governor Peter Shumlin, made that the sort of centerpiece of his whole career, was trying to develop a so-called single payer system in the state of Vermont, which unfortunately, financially, the state could not pull off. And that got recognized towards the end of his term, but an important amount of good work got done. And most of that work continues to this day, with Vermont trying to do as much as it can in the healthcare reform arena. And right now it's at the level of negotiating and renegotiating waivers and working with the Centers for Medicare and Medicaid Innovation, working with an ACO that's prominent in the state. I could go on, but the bottom line is we continue to try to provide for as much equity and overall high quality healthcare in the state as possible, and doing a really good job at that, even without having a revolution occurring, if you will, in our systems. But the goals are to really achieve that triple aim of great population health, great customer satisfaction and quality, if you will, and great cost savings, if you will, or working on the cost equation at any rate and providing a high value operation. The population of Vermont, I don't want to give you a specific statistic because it'll probably be outdated, but we're one of the states that's known to have the highest percentage of Vermonters who actually have a system of healthcare around them. Generally, the metric that's used is, do they have a primary care physician? And though primary care is stressed everywhere in the country and has difficulties with recruitment and difficulties with retention and people retiring, et cetera, we still have a very high percentage of our population who report that they have somebody that they consider their primary care site, if you will, of care, which is really, really important. And it really spills into all kinds of implications, if you will, because they have a starting point that they can embark upon, no matter what their issues happen to be. In our primary care arena, I would not say that we're that different from anyone else. Probably the rate of mental health issues is probably in the 30–35% range for what a clinician would encounter in their daily practice. Much of that is something that would stay within the practice and can be adequately managed on their own with referrals as needed, either to psychology sector and counseling or to physicians in psychiatry and in the mental health arena. And this also goes for substance use disorder. We're the state that's known as the founder of the hub and spoke system, where the hubs are really for more complex patients with substance use disorder who may require more daily visits to obtain drugs like methadone, versus the spokes, which are really predominantly primary care sites. So they also include some OBGYN, some psychiatry, and other types of clinicians, where most of those patients will be receiving buprenorphine on a monthly type of basis, with built in through our Vermont blueprint access to adequate counseling for substance misuse and/or mental health issues. So the primary care system is strong in Vermont and really does have a lot of responsibility, if you will, in the arena that we're talking about on this council, which is the integration of more of the physical and mental and substance use issues all kind of together and recognizing that. So I don't want to go on too much further than that because we want to hear from you. But before I stop, I want to turn it over to Allison, who will talk a little more about mental health, especially as she sees it in her role as a deputy in the Department of Mental Health.
Thanks, Dr. Levine. So Tracy, in Vermont, we have 10 designated agencies and 2 special services agencies, and they're basically our community mental health centers, and they are responsible for different regions of the state. And so when it comes to integrated health, you're going to see pockets of different models all over the state. Mm-hmm. So some may have more co-location models. For example, the Blueprint for Health has put many social workers in federally qualified health centers. Some of those you might find have someone there 2 days a week who's somewhat integrated into the practice. Others have 5. For those who have 5 days a week, they've stated that that's a better model because the person can be really integrated into the teams there. In neither case, it's my understanding, does that equal integration into the health record. So what we have is different people sort of placed into those settings, but not necessarily able to be a part of their entire record or enter information into their record. So even where we're embedded, we're still struggling with that sort of integrated communication and collaborative documentation for the full teams. We have some where it's relationship built. I think about back when I was a crisis clinician, I was across the street from a primary care. I don't know if people remember Dr. Fred Holmes, but he got to know us. And so when he had a client, particularly a kid, which was my focus, he had my phone number, my direct phone number. And so he could contact us and say, I'm going to send someone across the street. They're coming in. Here's what their situation. Or he would just call and say, here's what I'm faced with. Can you help? He was not somebody who felt like when it came to mental health issues, he didn't feel competent in assessing them himself. He did, however, have a really good background in substance use. So he just found people around him who could build that. And we have cases like that all over Vermont where people have just built a network of other people who can help them make some of these decisions. And so I think some of that's relationships, some of it's embedded, some of it's co-location. And then we have what's been some pockets of initiatives. I'll give you an example. We got some suicide prevention funding a year and a half ago. And one of the things we all decided to do with it was say, let's do a mini grant proposal, and we'll offer funding to any primary care office that raises their hand and says, I'm willing to meet for once a month for 6 months with a community mental health agency, and we'll come up with a pathway to care for someone who's identified as suicidal in my practice. So if I'm willing to screen for some of them meant officially, for some of them it meant just asking some questions. And if someone says, yes, I'm suicidal, what do I do? And they together made a plan. We had 17 practices raise their hand for that. And we now have 17 places where there's something more formalized and systematic about what you would do in that scenario. Take that example and pocket it in other places around the state. So we sort of have this hodgepodge, but very committed and well-meaning efforts. And I think what we haven't had necessarily is a systematic way to say, how do we interact? Who's responsible for what? Who's the lead? And how do we move forward? I would name OneCare as a place where we started to formalize some kind of concepts like lead care coordinator for a team that has people beyond their own agency. So, and I won't get into too much of that, but that's been, I think, definitely moved the system forward in some of those ideas and definitions about roles, what roles should be. And so where we're at today is, I think, this group, and when we meet together, especially in our small groups, we're finding we're learning a lot about the different efforts and ways people are doing integrated mental health care and healthcare based on the resources that they have and the initiatives they've been able to move forward. And we're trying to help each other join. You know, I've got this going on. Maybe can you join this, and we can spread, say, for example, we've gelled around the Columbia suicide prevention scale. So that assessment, the Columbia assessment. So rather than when you hear about other organizations putting something forward, you might raise our hand and say, if you could use that one, then we all have a way to be moving forward in the same direction. The other thing I would name, just for your awareness, which I think is really interesting about Vermont, is the community mental health agencies do a lot of healthcare. And so when you think about individuals with severe and persistent mental illness, which is the technical term that is used when it comes to the category who fit into that enrollment, when they visit their PCP, it's oftentimes in tandem with their community support worker. They might provide transportation. If they need a medication, it may be that person who helps ensure that they pick it up in time or that it gets delivered. If that medication needs to be in a refrigerator, it's the community support worker who's out there making sure they have a refrigerator, that it is stored there, that they're working on a behavioral plan to ensure that they can remember their medications for their diabetes, et cetera. They've always played a big role in that. And I think the next step is getting to a place where we can well utilize those folks in support of healthcare so that this can go both ways, both primary care assisting with mental health and vice versa. So those are just a few examples of where we're at. I think you'll hear a lot more from folks when we do some report outs.
It's really exciting and really helpful for me to get a little more context. So I appreciate both of you giving me a little bit of a frame for this conversation, and thank you very much. And I just want to say, part of the reason I'm really truly honored to be invited into the conversation with you all is I just want to say, from a national perspective, I know you know this, but I want to say Vermont can lead the way in this nationally. So not only are you doing tremendously important work for your state, but as you were saying, you know, Vermont is so progressive, and this is the whole country's trying to figure this out. So the degree to which the rest of the nation can learn from, you know, what's hard, what's difficult, what works, what doesn't. I just want to say rah, rah, because the whole nation needs this work that you're doing, not just the whole state. So no pressure, but that's the way I see it.
And just two other things for context, and Allison can hopefully validate what I'm going to say. We are known as a state that leads the country in, I guess, maybe the ratio of mental health practitioners to the population or what have you. Yet that doesn't always translate into optimal access to mental health care from the standpoint of the population. Whether it be an adult or child population. So it's one thing to have great statistics. It's another thing to have the reality base of what about if I want an appointment with X, Y, or Z type of clinician. And then the second thing, we've used the word blueprint a few times. Are you familiar with the Blueprint for Health?
Is it a Vermont state blueprint?
Yeah.
I have not reviewed that.
Okay, well, I'm going to bring it down to the level of the primary care practice to explain it the best. It's a system of care that really can augment what a practice or a practitioner can do with their patients in terms of access to a whole abundance of other personnel. So it's built on the foundation of community health teams. These teams may have within them people specializing in nutrition and physical activity and mental health in a whole host of arenas that can serve as a ready referral source for the primary care office, so that lots of the important work which occurs outside of an office visit context can continue longitudinally with a patient. And they would receive the benefits of whether it's counseling or other services that could occur through that. So it's a system that really continues. I'm not doing it justice, but I just wanted to put it into context.
That's huge.
And Allison can say whatever else she wants on both of the things I've just sort of blurted out.
No, I appreciate that. Yeah, thank you. We like to use terms that nationally you might not understand. I think the only other thing I'd say is we struggle, I think, just like every other state in right sizing care. We're just like everyone else, aiming for right level, right type, and right time. And I think when it comes to access, we may have gaps, and so of types of care, and so we end up either having people in higher levels of care than they need, or level of care than they need, and that gums up the system. And so we're looking at things that we've been missing. For example, intensive outpatient. We're pretty light on that in the state, and that can create issues with either people having to go inpatient when they otherwise wouldn't need to, or stay inpatient too long because there's no right level of care to take them back. And then obviously we're really big on prevention and health promotion in the state, and yet that's hard to pay for. And so we recognize, I think just like everywhere else, if we could have gotten ahead of some of these, we wouldn't have so many people needing those more intensive wraps of services. And so trying to figure out how to get out there. And we have a few initiatives right now, like mobile crisis response and some other like crisis text lines that we're trying to help get out to more people sooner so that we can have more access for the other services.
Why don't we launch right into allowing our guests to tell us a little bit about herself, how she came to this Whole Health Institute, and what this model is all about, sort of laying the sort of foundation for us all so we're on the same page.
Sure, I can dive in and definitely let's make it conversational. So I'm giving you information that's helpful to your work. I think when we've used the term whole health, and actually that term we birthed, it's used broadly now, which is interesting and a good thing. But we birthed that term actually back when I was still in the VA, we did that because there was so much confusion around at the time. A lot of people were using the language of integrative health or integrative medicine. And what that meant to most people was integrating complementary approaches, like acupuncture and different mind-body techniques and things like that. And while that's a piece of health and self-care, it's missing the point, actually. So, we thought we have a communication issue if we use the language of integrative medicine or integrative health. So we really kind of pulled back and said, well, what is whole health? What would be the right term for this? And I think we're so on the same page with what you all are, how you envision health and healthcare, because it really is a transformation that puts the person not just at the center of their care. The language we often use around it is that whole health empowers and equips people. So those are two, really distinct pieces. How do you help somebody get intrinsically motivated on the empower side? And then once somebody's intrinsically motivated to take charge of their health and well-being, how do you allow them to support them in the way you guys are describing with your community health teams? They need the skills and the support to do it, right? Once they're motivated to take on their self-care, it's not, even though the motivation's huge, when people are just trying to get through the day, and live in their life, you got to be really motivated to take your charge of your health and well-being, but it's not enough. So it's the empower and equip people to take charge of all aspects of their health and well-being, their physical, their mental, their emotional, their spiritual, and for the purpose of living their fullest life. And I can talk more about some of the lessons we learned as we tried to model this, because I think some of them may be applicable to the work you're doing. But one of the really big ahas was, we in healthcare, how we're trained and how the system is designed. My own conclusion is that we're starting from the wrong place. So we're starting from the disease or the chief complaint. That's the way and that's not a criticism of any of us in the system. It's how the system is designed. I mean, it's what the system is designed to do. And if we're honest, the healthcare system as is, which is why it's so exciting what you all are driving towards in the blueprint, the health system as is, it doesn't have the core competency of really supporting people in behavior change and self-care. It's just not designed to do that, right? And I think the crisis that we're in right now with health outcomes and costs is, of course, and COVID, is a huge opportunity for us to say we have to do it differently. Just doing more of the same isn't going to get us there. So I really think it takes a radical re-envisioning of not just improving the current status, the current way of doing things, but actually thinking about it differently. And let me pause there. I mean, I can go on and we'll talk. I know we'll go down into the layers of this conversation, but it's encouraging to me to hear how forward thinking you guys are already. Even as you describe the community health teams and the community support people. And anyway, so let me pause there for a minute and see if that makes sense as a kind of how we think about whole health and what that is. And then we can talk more about some of the lessons learned maybe. And when we tried to implement it nationally, we did a lot not right. And so hopefully that can be contribute to your learning and you won't have to repeat all the mistakes we made.
Thanks, Tracy. I think one of the questions we have is when you think everything that you just described, how extensively has the model been adopted?
Yeah, and I actually think I just had, we'll send around you guys interesting timing that on Friday, the biggest article so far, publication, I'm going to send it to y'all. But perfect timing that on Friday, the VA published this study looking at the implementation of the whole health system across the VA. And this particular work, we started really with just innovation grants, Allison. So because we said we all see the same problem. There wasn't a lot of argument about what we were trying to fix. It was just like, well, how do we do it, right? And thinking the same way and just making improvements in the current paradigm isn't going to fix it. But we didn't really know, well, what does it look like and how do we do it? So we started early on with nationally, we gave out over 200 innovation grants and basically said frontline people who are trying to do this with their patients and with veterans in that case, innovate. Let us learn from how you do this, and then we evolved that to we learned from that. We started to evolve the model. And I think the big piece of that was understanding, it's not just a clinical team that's aligned. It's also this peer-based empowerment that is so critical. The biggest mistake that I think we made at the beginning, and I laugh at it now, right? It's kind of comical. Because of course, like most of us are clinicians. So what we tried to do at the beginning was shove it all into mostly, Dr. Levine, primary care, right? So it was like, okay, in addition to everything else that primary care doc is trying to do and approach, now, and even people who were bought into the concept were like, and now you think I'm supposed to, because we were teaching people to change the conversation and help people pause and explore their sense of meaning and purpose in their life, right? And so the docs are like, are you kidding me? Like, in addition to this problem list, now I'm supposed to help people discover their sense of meaning and purpose in their life. Are you kidding? So it's kind of comical now. Like, why did we ever think that was going to work? But we did it first. I mean, we created the whole model and the tools to help people change the conversation and create a personal health plan and all that stuff, which was great. The mistake, of course, was like, we'll just shove it into the clinic. It's like, oh my gosh, of course that didn't work. So a number of the innovations were, first of all, realizing those kinds of conversations with people are better actually not only not in the clinic room, but not with clinicians. That's why it's exciting about your community support people, that really those kinds of conversations that are really driven at the empower piece and helping people stop and reflect on what really matters to them, really matters to them in their life. Like, why do they even want their health, right? Those conversations are best led by peers. And the great thing about that is it's also scalable that way, right? So that was a big aha, was like, oh my gosh, right? Like, that's not a clinical thing. Now you want the clinical teams ideally aligned behind that concept and that way of thinking and reinforcing it. But the real work in that shift in conversation is best led by peers. So we figured that out. And then the equip piece is, just as you described around, it doesn't really matter if your diagnosis is, if you're struggling with depression or cancer or your self-care, optimizing your nutrition and trying to move your body and deal with stress in different ways. That cuts across, right? So what's nice about that is that's not disease specific. So the equipping people with the skills they need to address their self-care cuts across all diagnoses and, and isn't specific, doesn't have to be parsed out like a clinical treatment. So the equip piece launched, and then we ultimately got funding to have 18 health systems once this was mature enough. And we had these three pieces: empowerment done by the peers, equipping with classes and instructors and skill building, and clinical teams that are aligned, all focused around the person. Once we developed it substantially, where we felt like, okay, we're ready to kind of roll this out and test it more completely. We did that initially in 18 different health systems, and that's what this study is reporting on. The VA is organized in networks, as you may know. So we had one flagship facility in every VISN, every network across the nation. So there were 18 facilities that implemented the whole model. And the outcomes are really quite impressive, to be honest, with a significant decrease in opioid use in those facilities that they compared the whole health facilities to the typical non-whole health facilities. And the veterans themselves had, and I'll send this article, much greater improvements in their own perceptions of their care, but importantly, greater engagement in their healthcare, as well as greater engagement in their self-care. So we were seeing what we were hoping to see. They also had a significantly increased sense of life meaning and purpose, which from my perspective, when we start thinking about mental health and suicide prevention, wow, if we can support people in reconnecting and to a sense of meaning and purpose in their life, that's pretty amazing. And so that data, again, just published Friday, or I just saw it Friday, and we can share that because I think there are a lot of lessons learned. The good news is, and then I'll come up for air, I don't mean to lecture at you guys, but the good news from where I sit is that you have all of the pieces, all of the parts and pieces, it feels like. And one of the things we learned in the VA, and this was also true a lot, the VA has an array and a broad depth of resources for veterans. That wasn't the problem. The problem was there wasn't any frame or process that actually drove the integration. So as you all are charged with integrating, primary care and mental health, the question I think becomes, can you put in place a frame, a model that actually becomes the driver of the integration? And that was a really impactful thing, I think, in the VA, where we have the circle of health. Everybody's got a graphic, and the circle has the person and their sense of meaning and purpose at the center. And when you really implement that approach, you can't help but integrate primary care and mental health, because it's the person that is driving the integration, if that makes sense. So even if the medical records are split, if the person, for example, has their personal health plan, their way of walking through their health and life, and they're sharing that with the primary care doc and the community support person and the mental health folks, that becomes a driver of the integration. And so I think that that's a big lesson learned, that the hard part with the resources and all of the pieces that you have may be missing the thing that's actually integrating it. But the good news is that's the easy part. The hard part is what you're already doing. But I think having a model and a frame that drives it into an integrated approach makes a big difference.
I appreciate that with the model and the frame. I think you might be aware this group is one of the things we're doing is reviewing lots of different models and frames. And I think, like everyone, the inclination is to try to grab pieces of some of them and make our own, just because we like to make things more difficult than they have to be. But it's interesting to hear about how that can be a driver, because you kind of have a path when you have that frame.
And just on a practical note, Allison, just so you guys are aware, any of the tools, including education, I mean, we have that the Whole Health Institute has created, which has evolved from the VA, which is all open source also, is all, open source, free, no charge. So to whatever degree it's of value, the education or the tools, we're still young and standing ourselves up, but because we are building on the shoulders of the VA work, there's a fair amount that I think maybe have helped you, which we can talk about offline, but just to tag that, that's the purpose of the Whole Health Institute.
That's fantastic, because that's where my head went. I think many of us on this call are interested in data, and we're measures folks. And so when you say a measure that looks at increases or decreases in meaning and purpose, I immediately went to, how are you measuring that, and how often, and engagement in all of those pieces. So anything you could share would be so helpful. And I think my follow-up question to that, you spoke to the outcomes for the patients and persons served. curious what the providers have to say about
Oh,
this.
yeah. Oh, I'm so glad you asked that question.
Their experience.
Yeah, because the other exciting thing is that huge impact on the provider side, such that there were significantly less resignations across all physicians, nurses, across all the health professions in the whole health facilities compared to the non-whole health facilities. And people, and then I'll just say this, so that's the data, which is great to see and important. And then I'll just say that from a subjective perspective, and I don't want to call out Andy too much, but I hope that Andy will speak up a lot and whenever, because you have your own personal experience of this. But I think that the subjective piece of it was people felt so relieved to have a system approach that allowed them to do what they wanted to do and practice in the ways that they valued. Like it felt like a relief, like, oh, it also felt like a relief because with our recognition that you can't just dump this all. I mean, again, the kind of duh, right? Like you can't just dump this all on the clinical team. It was a relief that they had, and just much like you described, Dr. Levine, with the community health teams, where you go, it's not all on me. Like and so what was happening is that people felt a relief, and their burden actually decreased. The primary patients that chose to use these approaches were mostly patients with mental health issues and or chronic pain, which of course are often hand in hand. So the big learning there was that these were people who were struggling and utilizing the systems a lot, and it made a huge difference because suddenly the providers, the clinicians went, wow, like I don't have to do it all on my own. Like these peer groups are helping these patients tremendously. They're getting, they're taking on their own self-care in a way that made it. That's why I think there was so much of a difference in opioid use, is that these patients were learning skills for them to address their own health and well-being. And the impact on the clinical teams was like, hallelujah, and hallelujah that we're not having to do it all ourselves. So I think that was fabulous to see too, and burnout decreasing and people returning to a sense of joy in their work again. Now, this data was all pre-pandemic. They're still collecting data and analyzing it, but we don't have the outcomes. So.
Can we have you fast forward a little to the post-VA part of your experience and maybe define a little bit more or give a better overview of whole health as it translates into what you're doing now?
Sure.
And how all of this stuff gets operationalized.
Right.
So, and then how it relates to the various types of practitioners and patients that they serve.
Yeah, absolutely. And that's, you teed that up perfectly because, okay, we learned a lot in the VA system, but that's a unique system, to your point, right? So how do we begin to translate that more broadly? And that's the work that we're taking on now with the Whole Health Institute. And the one thing that's interesting, and I don't know how applicable, well, I'll just share with you since you asked the strategies that we're prioritizing, because understanding that this is a big systems problem, right? This is not, we're not going to solve this with a tweak here and a tweak there. And there's actually multiple systems. We've identified 13 systems, and I'm sure you could slice and dice that a lot of different ways. But 13 systems that are impacting health and well-being in the nation that actually all need to have some degree of transformation. And I don't use that transformation word lightly. And people use transformation all the time, but I mean true transformation. And the way I define transformation is a system is transformed when the purpose of that system is changed. So, for example, if we're going to transform what a healthcare system is and the purpose of the healthcare system, And that purpose shifts from not only treating disease, which is important, obviously, but to really supporting people in optimizing their health and well-being across their lifetime. That's a system if we actually succeeded, that's a system transformation. So we've identified 13 systems, and I'll tell you the 5 that we started with, and I think it'll make sense why if I explain this well. But I think as a state, it's the same question, right? As you're looking across the state, it's not enough, as overwhelming as this sounds, it's not enough to just transform the healthcare system, even though that's huge and difficult and challenging and important. Healthcare system transformation is only one piece, because as we know, like where people live and work and make their day-to-day choices, and the issue of equity and population health, as you're talking about, that's not driven by the healthcare system alone. So we have the healthcare system transformation. We have community whole health, because we really believe that this has to live and be rooted in a community. So how does a community align in supporting its population, in addressing their self-care, in having conversations around meaning and purpose, like, across the community, of having peers trained across the community, of having these programs. I kind of think about even like how you can go anywhere in the nation and find an AA meeting or an Al-Anon meeting. And wouldn't it be great if you could go anywhere in the nation and find a whole health group, led by peers that you can drop into at any point in time? And of course, it can be done virtually. So the community-based approach is the second. The third priority for us is employers. And probably not surprisingly, employers are one of the few systems where the incentives are actually aligned, right? Because the costs of healthcare are, huge for employers, and they want a healthy workforce. So we're finding that they're actually more aligned and motivated to drive this transformation than the healthcare systems are, not because the healthcare systems are, evil, but because they're not incentivized right now to do this. So that leads me to the fourth area that we're prioritizing, which is health sector finance and policy. So in Vermont, I've already moved there in my mind, apparently. In Arkansas, very, very fee for service still. And so we have been driving and catalyzing the conversation between insurers, the employers, and the health systems to drive to value-based care. And one great thing is we were just named by CMMI as one of the 5 states that's going to be piloting this shift to value-based care. And it is interesting, Dr. Levine, like you were mentioning Arkansas, I mean, it's embarrassing, right? We're so far at the bottom of all of this. And the other states they chose, California, North Carolina, Colorado, I think maybe there's only 4 states, are great performers. So my team is like, well, we can show a lot of improvement. But so if we don't change what we value and what we pay for, it doesn't matter if we have the greatest approach and model, it's not going to be sustainable. And then the last of our initial 5 priority areas is experience and education. So if we are creating and providing experience and education both for these peers, we have training that trains the peer, and again, it's virtual right now and it's open to anybody and it's free. So if you guys have a place where you want to say, hey, let's get the community support people trained up in this approach, or let's pilot that, I mean, that could be a real practical thing, that we could easily do. So we have training for the peers, we have programs direct public, and then we have education for clinicians around practicing this way and skill building for the clinicians. So you can see by that expanse of that, the Whole Health Institute basically has said, if we're going to help drive this not in a closed system and across the state and nation, then we need to address all of these systems and be a catalyst for the change. And the only thing that makes me optimistic about it, well, not the only thing, I'm pretty optimistic, but the thing that makes me optimistic is everybody's been trying to solve this. There's great work happening in all of those areas, right? It's not like we're not birthing this, that people have been working in health systems and communities and workplace. Everybody's been trying to solve it. And so great work is happening. I think the role of the Institute can be to, I think that work has all been siloed, and so part of the goal we have as an institute is to integrate those conversations and those efforts across the silos. And that's hard work, but I think that's important. And that's really what I think we can provide, that as a service to the work.
Thanks, Tracy. One point of clarification that I think will be helpful for you and the group listening is in Vermont, when I say community support workers, those are employees of our community mental health agencies. And one of the things I would say, despite Vermont's progressiveness, we're a little behind in our utilization of peer supports and services in terms of having a peer certified group who can bill for their services. It's an initiative that's going forward now. I would say that doesn't mean that many of our community support workers have personal experience with mental health. We just aren't necessarily putting that to the forefront, and so that's something that's been talked about a lot in the past couple of years, is how does one identify as a person with lived experience who can utilize that in their work versus under the umbrella of the clinician. Even though community support workers aren't licensed, usually they're someone just designated to be in the human services field and hired for that purpose. So I just wanted to make that distinction, as we're really interested in how do we utilize our very willing peer community better. And so that could be an opportunity to, if there's, the state's ears perk up when you hear free training, so and publicly available services.
Yeah, absolutely. Because I think the grassroots movement, I'm sorry, I was just going to say, I think seeding a grassroots movement around this that really is from the bottom up is the driver, really, that, and so I think, and Vermont's a great place to do it.
Well, and I think when it comes to those community support workers, one thing we are clear on in Vermont is there are peer models, right, where you're utilizing some of your own experiences in that work. And so currently, most of our mental health staff are under more of that traditional model where we're the experts and we come to you, but we are working really hard to be person-centered in that. So I know for most people who do that work, they're asking, what are your needs? But they're not necessarily putting forward their own experience to assist. Those are peer models, and how do we integrate those more, and where do they best fit in? And I think you're describing a model where you figured out early on that it is best suited for that certain pieces. And so we'd be really interested in that. Back to the nuts and bolts conversation about what is this and what does it look like. One of the questions when Kathy was describing to me what I think was clear as like a certain value and philosophy that comes with this. But when you boil that down to what it looks like when somebody walks in the door to receive this, one of the questions I had was, what do you need behind those doors? So do you need to have the full team of folks who can provide whole healthcare in one place? And also, is this mainly a change of philosophy, and then you can have the people who had their previous roles buy into that and adjust? Or was this kind of a whole overhaul of a different assessment, a different business model, and different services and supports?
Yeah, so I think there's no one way, as in any like kind of large system, strategy, Allison. I don't think there's any one way. We learned a lot, and still are learning, because now we're doing this in with the health systems here in Arkansas. That it certainly helps. Yes, to your point, I think this is what you're getting at. We can talk about the philosophy forever, and people may even like jump on board and say that's great, but if we can't operationalize it, and so the tools are really important. And sometimes, as I'll use an example. I was a psychology and sociology undergrad, and then when I went to Duke Med School, I was like so excited about the social history and like really understanding my patients. And you know how this story ends, right? The first rotation on the wards was like, oh, we don't have time to ask those questions. Like, what are you doing? I was like, wait a minute. So quickly, the way I practiced was driven by the form and what I needed to report out on. And, so these processes, the other valuable thing about this is these processes can also drive the change. So maybe people aren't necessarily aligned in the philosophy, and I'll give you a really quick example, actually, from a primary care doc in Boston. So this is a woman who shared the story, and I think it's a good story because it gets at what tools do we have, and can tools actually make a difference? So this was in Boston, and there's kind of a different intake form for whole health that's asked people. I mean, some of the 3 questions we added because we were trying to work on the suicide prevention side of things. And okay, now I'm going to tell 2 different stories, if you don't mind. I'm looking at the time. We have time because I think they're illustrative. That the first one of the big ahas for me and our team was a facility director shared about a suicide of a veteran, and I think it was in Dallas. Not that matters, but he was sharing the fact that this particular suicide was especially impactful and distressing to the primary care team. And they have patient aligned care teams, right? So they have a whole team, and mental health was integrated, and the team they thought they knew this patient really well. And he had hypertension and diabetes, and his hypertension was well controlled and his diabetes was well controlled. And he was seen there and known by the team, they thought, very well. And a great caring group of clinicians, including mental health and primary care. And they were really astounded to find that, when they talked to this gentleman's family, they said, "Oh, he was suffering." I mean, it wasn't a surprise to them that he had died by suicide. And so the team was deeply disturbed. Like, how did we miss his suffering, right? And the reason they missed his suffering was not because they weren't compassionate, wonderful clinicians, but because they were doing what the system had them do, right? They didn't ask the question. There was nothing that brought forward his suffering because there was no tool or process that surfaced that. So one of the things we changed right away and piloted, that's part of what we call this personal health inventory or personal reflection, was 3 simple questions. And these were not designed to be measures. It's interesting because now everybody wants to use them as measures. So they're not validated tools. It's an intake. But the 3 questions were, on a scale of 1 to 5, where 1 is miserable and 5 is great, how would you rate your mental health? That's 1. How would you, and I think we put mental, emotional, spiritual, so we could catch a big, a non-physical. So how would you rate your mental well-being? How would you rate your physical well-being? And how is it to live your life day to day from miserable to great? And we went, we're not necessarily going to catch everybody's suffering, but that's going to change the conversation. And so implementing that, something like that, that's at the intake side, I think can have a huge impact on this. The other example I was going to give is a primary care doc in Boston, and they use a similar tool and what we call a whole health review of systems. So it's like a typical review of systems, but it also asks around the areas of self-care, like how would you rate yourself in your, nutrition, your stress, your relationships, your, and around what we have, these areas of self-care, which are not going to be surprising to you. And so she was seeing a gentleman who came in for knee pain, and she had seen him before. He was a patient of hers, and she's like, "Trace, I'm like doing the workup for the knee pain, and getting it all tidied up." And she said, "I glanced at his review of system, his whole health review of systems, and I noticed that in relationships." Oh, that was the other one. The other one was sleep. So in relationships and in sleep, he had rated himself like the lowest possible score. And so she said, I stopped what I was doing and I said, wow, I noticed that you have, rated this really low. At which point he burst into tears. She's like, this is this huge, big, burly guy sobbing about he was going to take his life. And he just couldn't figure out how to get through the day anymore. And she was stunned because I was going to miss that. He came in for knee pain. I was working up his knee pain and I would have missed it. So I think the tools can be really powerful and they don't have to add a bunch of burden. This is like it's like an intake form you do before your visit, but it can help change the conversation and highlight what we're missing in ways that are really important. So I think sometimes just a simple change of the tool can have a huge impact in the way we practice and the way we care for people.
Just have to say before we go on to the next question, how meaningful I think that is, because one of the things that I think I've seen is because we want to know so much about the people that we serve, sometimes we try to turn providers into researchers. So it's like, well, we want to know how well they are, so let's put together a 50-item validated tool to tell me if they're this, and then we'll do another one to tell me if they're that. And there's two pieces to that. One is the experience is often subjective. And so, one thing, community mental health providers and primary care providers are not in that role as researchers. And you will never get the type of, timeline on reassessment that you're going to need to ever utilize it in that way anyway. And so sometimes just asking a meaningful, subjective question about how someone's doing, and so many less of them, because you're just asking the direct question, then it's about communication versus validation. Mm-hmm. Plus, you're getting away from some of those tools which have been steeped in white supremacy and ableism and other issues.
Absolutely.
I'll take myself off mute for a second here. So that was a great example of the clinician was almost, though, inviting the burden of everything on themselves because they discovered this during that visit, which then could have led to that patient occupying the rest of the morning.
Yes.
Give us a little input on the sort of integration part of that and how that clinician, how the integration with community service providers would occur, how challenging it may be, but how it can get affected in that way. What do you need to move into this kind of approach that the tools may not be there initially, but they're needed. You've described the intake process as changing. Is there other aspects of the business that are changed? New assessment models for the staff, change in who is on the staff.
Yeah. Yeah, great questions. And I would say I laughed because, I think the staff need to be aligned. And you all know this, right? Because change is hard. And people get very attached. We're human beings, right? So we get very attached to our own way of seeing things. And I'm always surprised, but not so much, that if you're trained in a particular way, and you're trying to do the right thing for your colleagues and your patients, you're going to revert to what you know, because we all do, right? We all do. And so I think part of the challenge, my guess would be, even on the group that you're in, is how do we get out of our, I call it already listening, that our belief that this is the way I was trained is the way forward. And now if I can only convert everybody else to see it my way, everything would just be fine, you know. And I'm sure some of that is because this is human nature, right? And we're professionals and we're vested in what we were trained in and what we know. And so the challenge is getting, and this is as true at like a system level as an individual level in a clinic or in a community environment, that how do we step out of our right, wrong way of thinking? You know, I'll debate you and show you that my way is the way. And again, with the best of intentions, because we're trying to move forward and flip into what I call conversations of possibility, which means we're stepping out. We have to be willing, and it's a vulnerable thing, right? Because I likened it to religion almost. Like people have their religion of the way they were trained and the model we grew up in and the model in which we practice. And it feels like, you know, a lot of people feel threatened, understandably. And I think we need compassion around that. Like, it's not surprising that people get kind of hunkered down in their way of seeing things and their way of doing things, because, you know, it's just, change is hard, and it makes people vulnerable because maybe their role is going to be different, or maybe they're not going to be valued in the same way. Not that that's all at a conscious level, but so I think you see that I think that kind of conversation, the reason that I drive from experience and education is, I think the only way to get people out of that kind of, well, I've done it this way, this is the right way, is for them to have a personal experience in what this is. And so for the staff, for example, like, and we had a huge employee whole health effort that it was part of the rollout in all of those facilities, is to give the employees themselves an experience of their own health and well-being, their own whole health. And then what happens is they have their own ahas, right? They go, I get it. Like, most people have never reflected on what brings them a sense of meaning and purpose in their life. I mean, the times that most people do that is usually around a crisis. They get a cancer diagnosis and they think they might not have long to live. Now they stop and reflect on those kinds of questions. But you know, my hope is that let's not wait for the cancer diagnosis. Let's give the gift of this reflection to each other. So a real driver around the staff, and are they on board, or are they going to try to take it down, and all of that, the importance of giving the staff the experience themselves is critical. And then the other thing you'll find is that you'll have advocates and champions in places you never even realized. Like, I mean, people just start coming out of the woodwork and go, I care about this. I want to be a part of this, you know, and maybe they're a healthcare provider, or maybe they work, you know, in environmental services, and you get people across a workforce that are on fire about it. And now it's like the grassroots community thing. That is essential. You can't do it just from the top down. I mean, you need the policies to change. You need them, you know, that's important. You have to do, I call it top around, but the real driver is bottom up. And once people have an experience, a lot of times they shift into conversations of possibility, and they shift out of feeling like they need to protect their turf. And that's super important.
I appreciate your point about getting buy-in through experience with the staff. I mean, I talk with a lot of providers. I'm a provider in my background, and I don't think I can't recall a time where someone asked me, you know, about my purpose or meaning as a provider, and how meaningful that might be right now for those who are questioning it after being a provider through this pandemic and giving so much, and also struggling with all of the stress in their own lives as parents with school shut down or caring for older folks. Right. And so I feel like it's a great buy-in activity to actually help them experience what it's like to be asked those questions. Mm-hmm. I am curious, we talk a lot about this in this group. How do you, in terms of well, I'll name this, one of my roles with Kaya Ganguly, who's on this, is to chair a workforce development subcommittee of this council.
Oh, great.
And our charge is, what type of people do we need to have in Vermont who can provide holistic health care? Mm-hmm. And so I'm curious, when you thought about this and then translating that thought into practice, did it end up with more holistically trained providers, or a better network of providers, or a better path to getting people where what they need?
Yeah.
Or all of the above.
My answer may be frustrating to you, Allison, because I would say yes to like really all three of those things. I think I'm a big fan of mapping stuff, right? So for example, we have this circle of health and well-being and the different areas of self-care. What's great for communities to do, and because again, often there are many resources, but they're often fragmented and there's not an easy way to see them, to refer to them, to understand. So just starting with a mapping exercise where whether it's within one place, most likely it's not, but we start to say, oh, okay, for nutrition and food issues, we have these resources, and start to map the resources so that to your point, the clinician can't do it all and needs not to do it all. But if the clinician, whether that's primary care or mental health, introduces the idea and the concepts and use those tools, and at the end of the visit can say, I don't have more time to spend with you. They don't have to say it that way, but the fact is they don't have more time to spend with them. But there's a whole health group, or whatever you guys would decide to call it, that they can join and drop in, and they're going to learn about those self-care strategies and what's available in the community. So again, it shifts the having that cohesive frame of a group that knows the resources in the community, that's peer-led, that aligns behind the model, that can be referred to and supported philosophically by the clinicians is a great way to do it. And typically, like here in Arkansas, the resources are scattered about the community, and the issue is, again, can you integrate those with the person at the center, and drive it that way? So again, probably a frustrating answer, because I do think it's kind of all of the above. And yeah.
But it sounds like you're saying the provider would at least need to know enough. They would need to know enough that a referral is needed for some other type of holistic care, an idea of what those resources are, but they don't have to be everything to everyone.
Yes, that's exactly what I think.
And is there co-location of resources, or are these sort of referrals outward into the community?
Yeah, here in Arkansas, it's mostly the referral into the communities. One of the health systems is building a whole health center, but from and that's fine. But from my perspective, the challenge is if we're going to make this equitable across all communities, then I don't think a whole health center is a scalable. I mean, if you're lucky and you can have that, that's fabulous. But I don't think it's as scalable as, the kind of integrated, the peer groups that then refer to the community resources. And we've also done a lot of work. And again, I don't mean to sound like we've got it figured out down here in Arkansas, because we don't. But I will say that there's been a lot of interest and uptake for community-based organizations who are already trying to help the citizens and their communities to uptake this approach. Because again, it's just a model that helps them do what they're already trying to do. And so they're training peer facilitators and offering that through their community-based organizations. And so that's a useful strategy as well.
You did mention CMMI previously, and one of the 5 sort of pillars of what's going on. Can you give us a little bit of insight into how the payment system is being impacted, how it might be in terms of the appeal of this to the payers, and how they view the model itself?
Yeah. So in this regard, we are in a unique situation, I think, because of course, Bentonville, home of Walmart, right? So in this community, we have Walmart internationally headquartered here, J.B. Hunt, which is another Fortune 100 company, headquartered here, Tyson's headquartered here. So 3 Fortune 100 companies and a bunch of other companies here. So we had an advantage, Dr. Levine, of bringing, because to be honest, I think if we just tried to shift the payers, we would have failed miserably. But we had the opportunity to bring those, not their HR people, but the CEOs of those companies to the table, which is a unique opportunity, right? But we took advantage of it. We're like, we're not going to waste a good opportunity. So we had the C-suite people from the big companies in the region together with the insurers, basically. And if they say, this is what we want, Blue Cross Blue Shield goes, all right, then that's what we're going to do, right? It's such a driver here. So not that it's that simple, but that's essentially what happened, is that the big employer said, we want to move to value. And so you guys figure it out. And then we broke into a bunch of work groups and work streams across the year to say, okay, how do we begin to drive to value? And it's going to be long and hard, but the value of that, of course, is that once you have a payment system that's based on value, now the health providers are going, holy cow, we have to change what we're doing, because we're not designed, we don't have a system that's designed to optimize health and well-being. And now that's how we're going to get paid. So, obviously aligning the incentives is a huge part of getting the health systems to change. Because at this point, even the health systems are pretty on board with this, but if they're not getting reimbursed for it, you guys know, good luck, right? So it's a complex system, and we're very fortunate. The employer side of this is an unusual situation here, but we're hoping we can model it and get the data and then share more broadly that kind of transformation from what I call the living laboratory that we're in here.
We have a similar living laboratory. We, well, and at the Department of Mental Health, we've actually moved to value-based payment. And since we started the process around 2017, 2018, but it was enacted in 2019. And I would say, and I'm sure many people on this call would agree, we have the framework there. Where we haven't gotten to yet is enough standardized ways to measure value so that we can fully move away from having to count widgets. And that's a big transition. And I think one thing, like any transition, is the worst part of it is living in both worlds. Because until you get there, you're doing a lot of the old while also doing the new. And I think that's
between place is it's definitely the highest risk place in any transformation. And the other thing I should mention to you guys is that the NIH, this is interesting. So the NIH is putting, I think the RFI just went out. They are taking on this question of how do we define and measure well-being. So this is really cool. So they're saying, they're starting by asking entities, people, individuals, what factors do you think are a part of your whole health? So is it a sense of purpose? Is it just, and so they're getting the factors, and then from that work, they're going to then attach the measures. So I think nationally we'll have some guidance. That's going to be a process, but I'm really excited about that process, because you're asking the same things that we're asking, which is, well, what is it really, and how do we know if we're impacting it? So that work, we'll keep an eye on that work. I'm a part of that stakeholder group, so that's the only reason I know about it. But it's going to be very interesting. And I think if we can, you get, one of my other mantras is you get what you measure, right? So if we change what we measure, we're going to change people's behaviors. And if we don't, we're not going to.
Yeah. And how do you have some integrated accountability to those measures? Because we think about, for one thing, I know it's hard to put a measure out there that someone's accountable to or incentivized to, ergo their money is dependent on it, yet they don't have complete control over that for the client that they serve. And so, they're one piece of a puzzle. And so you really need the whole system working towards that aim. So then people would feel more confident in saying, no, I agree, that's a good incentive measure for us, and we're willing to put ourselves at risk for it because we have a network behind us.
Right. Right. That's exactly right. I was going to say the same thing, Allison, that it helps drive, again, it helps push the integration when you go, oh, I can't just control it all myself. I guess I better play nice.
Yes. One other thing that came up we were curious about is how does a whole health model with engagement and the type of person-centered purpose and meaning that you talked about fit with children, adolescents, and families?
This is an area, because so much of that development was in the VA. We didn't do a lot of modeling around this with children and families, but we are now in the Whole Health Institute very interested and engaged in that. And I think, can I say something that's not public knowledge? I can do that, right, Kathy? I just tag it that it's not public knowledge. Okay, so tag this, please, not to be shared outside of the group, because I think there will be a big announcement about it. But just last week, the Aspen Institute, which you guys are probably familiar with, I always think of, don't quote me on this either, I always think of the Aspen Institute as this place for really rich people that have time to go and reflect on the meaning of life and stuff, but I think that's not actually fair. So they have this big initiative, which I'm really interested in, that they are launching with I don't know if the right label is underserved youths. And their focus is across the nation. They have this network, is to begin to help these young people look at the question of meaning and purpose in their lives. And that has been totally independent of us, right? That they are like, and when we learned about that effort, we are partnering with them, and now we are providing, this is the part that will be announced later, not we personally, but the foundation here is providing a big chunk of money across 3 years, so that we can support that work, but also use it to pilot the entire whole health approach for these kids. And so that will be really, I think, the first big effort. We've created training, we've created the whole health model for kids, but we haven't really deployed it in any significant way. So that will be really exciting. And the feeling is, we think about, well, now I'll date myself, right? Like, well, why did we all start wearing seatbelts? Because the kids brought it home from school, right? Why do people stop smoking? I remember being a kid and stealing my aunt's cigarettes because I knew they were killing her, and she wasn't very happy about that. But so, again, I think that the children is a tremendously important doorway in that we do not have experience with yet, but we will be getting that experience. And I can keep you posted on that Aspen partnership, because I think that's going to be super interesting.
I think we have time for maybe one juicy question before we go into
those are the best kind.
Well, no, it gives you a chance to do some of that reflecting that you talked about, because you've had a fairly long journey with this now through the VA system and now through this institute. And I'm sure there are important lessons learned that you can now look back and go, gee, if I'd only known that, it would have made what I'm doing now so much easier to accomplish. Can you give us a couple of those sort of pearls or key learnings that you've had along the way that we should take into account as we begin to envision the future that we all have our own separate visions for, but we're trying to coalesce into a grander vision?
Yeah, for sure. The first thing that comes to mind is my observation of the process of really driving large system change, which is what you all are challenged with and charged with, and it's a huge opportunity. And I think the thing I would reflect on is that I have learned that initially, oftentimes when you're trying to drive change, initially you don't meet a lot of resistance at the very beginning. And my reflection on that is it's because nobody takes you seriously. It's because they're going, we don't need to worry about them. Their time will expire. They'll go, or, the next person will come in, and we're not, so it's an interesting experience when you're in in the position as you all are, as being leaders in this transformation and having your own, this is hard for you all, that oftentimes initially the resistance is pretty low. And then what happens, and I've always told my teams, is when the resistance increases and you feel like, what the heck's happening? Why is everybody out for us now? That is actually, and I mean this sincerely, a huge sign of progress, because it's because people are going, holy cow, they're going to do something. They're really going to change something, and that's going to impact me. So then you see the resistance pick up, and I think it's important because it's a slog to do any real change. It's hard because if it was easy, it would have long ago been done. So what you guys are doing is super hard. And I think it's very important when you hit a lot of resistance to actually remember the resistance is because people are threatened and you're actually making progress. And people are now going, oh crap, like this might actually happen. If the one after that phase, and I'm watching our times, yeah, I'll finish this up. After that phase, if the resistance declines, one of two things has happened. One of two things has happened, in my opinion. Either you have succeeded and the shift has happened, right? The system has shifted and flipped. And so there's little pockets of resistance, but there's not this massive like resistance, or you got co-opted. So people might use the words differently or, but real transformation may not have happened. And you see this a lot in this world where people are like, oh yeah, that whole health or, whatever label, that's the N word. We'll say we're doing that. And they might sprinkle a few little things in, but they haven't really transformed anything. So you have to watch for that too. I think that there's real change is hard, and you guys have this tremendously fabulous opportunity to do it, and resistance is going to be real. So I think that'll be the end of my juicy answer.
Great. Well, thank you. Thank you, Tracy and Dr. Levine and Allison. We're going to go into small breakouts now so that people can ask questions. We'll collect those questions and then come back